I'm very happy to introduce our next speaker, coming from Catalonia, Jordi Piera. And Jordi has a lot of experience with different pilots, and not only pilots, but seeing ideas through from the testing phase through to actual implementation. And I've also heard that Catalonia is a very lively place for different startups and a very lively ecosystem. So you can also ask him questions either after the presentation or during the presentation. And I'm giving the floor to you. Go ahead.
Thank you. Thank you for having me today in here. It's very nice to be in between friends, all the new ones. And yeah, I will try to explain you from my own experience what does it take to bring to scaling up beyond pilots. So at the very beginning, just a short introduction of where I come from. I come from a city called Badalona. It's to the north of Barcelona, totally attached to it. A very populated suburban area, 500,000 population. And I work for now 18 years already in a service provider. It's quite a strange service provider because we do not only provide from the health services, the full continuity. So we have hospital, primary care, we have intermediate care, home care services, and community mental health, and yeah, all the full continuity of healthcare. But we do also provide from the social services that are normally entrusted to the city councils. That happens because our city council is the owner of our healthcare organization. So back in the day, back in year 2000, we decided to merge both provisions into a single one. So now the point of my presentation and my discussion is that there's a lot of services, products, and even processes, innovations that are reshaping the way we understand health and social care. And we are able to do a lot of pilots, but it's difficult to scale up them. And then, yeah, there's a lot of case studies and a lot of evidence, most of it about the ones that have been successful when scaling up, but there's no magic recipe for scaling up every other innovation. So what I will try to do is go through my own experience and identify some domains that I think that they are critical and see whether you find something interesting in there or some takeaways or learning points. So that's the thing that I was asked by Piret to talk about. One thing is the roadblocks on the way. Some of them may look like a big rock, and which is the strategies that we are using to get them outside of the road and be able to scale up all these pilots. So this won't be scientific at all. I will put in place the barrier and then the things that we have done in Badalona to tackle this. So those are the key areas that I have found when thinking about preparing the presentation. This has been challenging for me because I was never asked to present such a thing. So this is brand new for me. So sorry if something doesn't make sense. I have identified these 5 key priority lines, which include, well, the sociocultural aspects, the network or the ecosystem. In here today, I guess, we have the Estonian ecosystem, the one in health. Then the evidence base, which is very important also when we are talking about health and social care. Then policy and funding, and finally implementation. So I will go through each of those. Telling a bit about which I think is the barriers in there, and then how do we tackle them. So that's the typical, I mean, if you work in innovation, that's the typical graph that everyone shows. That one is a nice version of previous older versions. This is from the Health Foundation. And it talks about, the aspects as everyone is, so the characteristics of any other person out in there. So we have a small percentage of people that are the innovators, then we have the early adopters, and then we have all the rest of the population that when scaling up, those are the ones difficult to target and those are the ones that we stratify according to the speed of adoption. This is nothing new. That's what I was telling you. We have the same graph from 1995, and this may think, wow, this is quite old, but this was identified even before. It was identified already in 1943. That's the same graph from 1943. So you see the difference, but nothing has really changed in all this time. And we are still finding, what are the solutions? But the truth about all of this is that, people is reluctant to change in general, or the amount, or the majority of people is reluctant to change. So maybe starting in here and up to the end, we have to put in place very nice strategies to convince them to be part of our innovations. I think that there's a characteristic that distinguishes the healthcare sector in between all the others. And that's that the medical profession, and that's my thinking, and I'm sorry if there are physicians in the room, but I think that, and I have also, it was in Estonian, but in one of the questions I think that someone said that medicine was conservative. I think that medicine and also the faculties of medicine have a problem. I mean, I think that they should change the way they are teaching, physicians specifically, for them to be able to adapt to the new times. I think that they are still living in this world where they had all the books that hold all the knowledge, and you know that this is not anymore true. I mean, all the knowledge is out in there, in the net. Patients, we see that with patients that they have rare diseases, that most of the times they know more about their rare disease than the physician itself. So this democratization of the information has changed a lot the landscape, and that's I think that's one of the barriers that we have when convincing physicians to change. Of course, there are innovators inside of the physicians, but in general, the profession itself, I think it's again very, very, very conservative. What we have done to tackle that? Well, we have identified that because of these sociocultural factors, it's very important to involve the physicians, and not only the physicians, all the other stakeholders in the loop, but this will come later in the ecosystem. But what we have done in here is two main things. One thing is recognize innovation in our strategic plans. This is the strategic plan from the organization from 2008 to 2011, when we put innovation as one of the key priorities of the organization. In there, our idea was, well, you can really read it, and if you could, it's in Catalonian, so it wouldn't make any sense for you. But the idea was that we want the professionals that are innovators or that have ideas to empower them and help them move these innovations forward. So we created an innovation unit that collects all the ideas that these professionals have in our private network inside of the hospital. They are able to put the proposals in there, and we have this multidisciplinary team that does the assessment of the innovations, and we help them, making them become true. We may help them through finding funding out in there, or we may develop it from the IT department on our own. The idea is to have the professional empowered and themselves being the leaders of the project at all times. So it's not that we will do the project for them, that they just put the idea, but they are the ones that will be the project leaders during all the process. And that's, well, one of the things that we have found that works when trying to overcome the sociocultural problems. So some takeaways from here and what we have learned. Well, I think that's my personal thinking, that the faculties of medicine should reshape the way they are teaching professionals. The second one is that working with nurses, we have seen that they are more dynamic than physicians and more adaptive to change. And with nurses, we have a lot of projects, super nice projects that have been very well established and scaled at the organizational level. Something else is the trick of involving the professionals since the very beginning in the overall process. It's the idea of what I told you before, having them as the ones that lead the overall project, and they are somehow the champions that are able to ease the buy-in process of the innovation and convince the others to join the crowd and continue using the technology. I think this is key at the innovation level and also when scaling up. The top-down approaches, well, are not always good, so it's better convincing the people and having them on board at all times, other than forcing them to do something that they want to do. Something else is that, well, we have found time for them to be able to do the innovations. You know that clinicians, they have a very tight schedule. In Spain, it's quite nasty, especially with the GPs. They have very few time per consultation, like 7 minutes, so we need to find a spare time for them to be able to lead these projects. So we have put in place these resources to free them from their clinical time. And my personal thinking is also that we have a system that is rewarding a lot the innovators, and they have a lot of recognition, but we are not focusing enough in the ones that are able to scale up. So the ones that will receive all the awards or all the professional recognition is the ones that innovate, but not the ones that are really managing to then sustain the innovation over time. Moving to the second barrier that I found, the network or the ecosystem. With this image, I wanted to say that, yeah, we believe that lone inventors or lonely innovators, they can move forward an innovation and maybe during the piloting stage, but when you want to scale that up, that's more difficult, and you need commitment from a wider ecosystem to be part of it in order for the innovation to properly scale up. So what we have done in Badalona is that we have built on the ecosystem that we have surrounding the city. That's covering the so-called quadruple helix of innovation, where we have academia and research, we have the civil society, we have the government and service provision, and we have the industry. So we coordinate this group. This group is called the health boards, and we meet every 2 months to see what are the challenges that the city is facing, and also to decide on, well, what are the priorities, and from these challenges and these priorities, they may emerge some opportunities for industry. So we have the industry in there that is able to propose us solutions or help us developing the solutions and the innovations that we are not able to move forward. I think that right now we are 57 partners in the city, meeting periodically every two months. The second part in here, and I think that's key in our situation, it's community building. We move from the elderly community houses, we move all around the city with the third sector, with the volunteer organizations, and we work very close by with them. So in here, well, you have some images of all these meetings. All these people are the professionals leading the health boards. And you have in here nurses, you have physicians, you have people from communications. And well, this is examples of some of the meetings that we have. So a strong focus in community building. The last part of it is the international networking, and it's what you are doing today now in here, which is there are a lot of opportunities out in there, and there is a lot of people willing to share their knowledge and to share their experiences. You should be taking advantage of that as we are doing. Europe is, well, full of opportunities, either public, private, and you should be part of it. That's my recommendation. When the takeaways, when it comes to the ecosystem or the network, what I told you before, the lone champions are good for the innovation level, but when it comes to scaling up, it's better to have implementation vehicles, I don't know how to say, a huge crowd of people working for it. It's also smart to build on communities such as we did. and in between this community agree on which are the challenges, which are the goals, and share them, and then the innovations will scale up better other than if you are doing on your own. And then probably the last part is, well, having all these 4 types of stakeholders that I told you before, we have found that when working all together with those, the innovations scale better. So when we have a representation of academia, research, civil society, and also policy making and service provision, innovations scale better. So it makes sense to pack all these types of stakeholders all together around the same table. Third barrier, evidence-based. We are working into the healthcare environment, and of course, evidence-based, it's very important. It's important because we need to demonstrate that our innovations, or the innovations that we are trying to put in practice, are worth for the citizens, and that they are good in terms of health outcomes. That's a minimum, I would say. And the second one is that, yeah, we need to demonstrate to our policymakers or to the people that is making the decisions that they are economically sustainable, or that they improve the healthcare expenditure. That's another of the dimensions that I think it's important to tackle. There are other dimensions, and Liz, when she did her presentation on the M-Health assessment model that they have in ORCA, they are tackling other dimensions. Those are also important to take into account. So what we have done in here is adopt, on the one side, as a strategic framework for assessing all these new innovations that we are putting in place, the MAST model. The MAST model is a model that came from a European project, the Method Element project, and also, well, from a previous one. It's an HTA, a health technology assessment methodology, that proposes you a series of different domains to be assessed. What we have done in here is crossing. We have come with the idea of a triple axis model, where we have all these assessment domains. We have all the different stakeholders that are involved in the provision of care, and then we have the use cases that our solution is covering. So proceeding in such a way and thinking about how to assess the innovation, proceeding in such a way, helps us to have a view from all the different perspectives. And so you have information to be given to the patient or to the policymaker, and you don't forget anything. So that's a really structured way to proceed with the assessment of and to generate high quality evidence base. When it comes to the economical part, we have also been testing, and we have decided to adopt the MAFEIP model. It's also emerging from the European Commission, and it's a model that we are using to assess the cost effectiveness analysis. This is very interesting for our policymakers. I won't tell you that it's easy. It's not easy, but any economical evaluation in health is easy. So when you are doing health technology assessment and you tackle the economical part, it's never easy. But well, it's a tool that when you get used to use it, it can really help you to even make future prescriptions on how will be the costs of introducing your solution into the market. And when scaling up, well, it gives you a good tool and good arguments for your policymakers to be able to sell this. So the takeaways with this is that, evidence-based or delivering a lot of papers, it's not a strategy on itself. It can help, but it's not a strategy on itself. It should take, or my view is that it should take all the perspectives from all the different stakeholders into account, so you don't need to forget about any of the stakeholders surrounding it. Of course, it must be quantitative and qualitative, so we are talking about a mixed methods approach. And you must think, and that's also a point, that even though the physicians or people may be requiring the evidence-based, most of the people is not ready to understand a scientific paper. So you must think that, well, there will be some times that you will need to simplify this research into leaflets, into something that it's understandable for everyone. That's a recommendation that I'm making you. There's another barrier, which is policy and funding. In here, well, we can leave out from, it's something, the funding and the policy making that can help us kickstart an innovation process and also the scaling up process. But it's not a tool in itself to sustain this change. In fact, I wanted to put you an example of, that's some of the European projects that we have been part. Europe is a good source of funding for innovation, for research, and also for scaling up. And I can tell you that from all these projects that I've been part of, only these two ones are the ones that have managed to scale and to be sustained over time. One may think, well, that has been a huge waste of public money. Well, we have learned, and I will go, later on I will go to this project because we are getting interesting things from here. So, my point with this is that, the financial incentives and also policy making can help the kickstart of the process, but it's not always, it won't grant the sustainability of it over time, so the acceptation over time among professionals. Of course, it helps when you align the innovation with the national and local priorities. And we have another barrier, which is that one is local. I don't know if this is happening also to you here in Estonia, which is that we are able to deploy projects that we demonstrate in the context of the project that are better for the system, that we are reducing hospitalizations or emergencies, or we are reducing in general the costs for the system. But this goes against our budget because our financing system in Catalonia is based on activity. While, so we get paid by the amount of people that comes to our emergency department, or we get paid by the amount of hospitalizations that we do. This is what I call the perversion of the financing system. So we have some of the innovations that I showed you previously that we have not been able to scale them because we have a main barrier, which is the financing system, the local financing system in Catalonia, which is not outcome-based, but it's activity-based, and that's quite sad, and we think that we need some rethinking in here. Something else is, of course, spin-offs and private companies are more dynamic than the public sector, and that should be something that you should be promoting, and the link in between public and these spin-offs. The last of the barriers, and this is a very difficult slide. But with this, I want to show a mental process that I have followed, and that it has been by a matter of a chance, but it really makes sense for me after going through it, and it helps me to introduce you to this implemental project. So we have an example in here of, concretely with internet-based mental health interventions, where we were able to do some basic experimental research in the laboratory with a project that I will show you later on. After that, we have been able to do some clinical research on the top of that. After that, we have been able to introduce that into routine and check whether that's something that scales or not. And finally, we want to see what are the implementation strategies that would fit better for scaling up this project. So that has been a chain of different projects funded by the European Commission. So we had the proof of concept, we had the blending in the routine care, we had the demonstration that upscaling was possible. We have been able to sustain and improve this, and now we are in the process of accelerating uptake through implementation science, which is this trendy, new, fancy science that it's now, I mean, maybe you are not aware, but you should look at because it's becoming something. So for me, that was eye-opening when I went through a paper from these two guys, Carl May and Tracy Finch. I think it was back in year 2016, something like that, which is called normalization process theory. And these guys, what they have been studying basically is what are the factors that may influence positively or negatively an implementation process of whatever thing. So we took the chance that we had this mastermind project. The mastermind project was successful, and we wanted to further research on what were the barriers towards scaling up the ICBT intervention that we had in there. So we were able to write this project, it went through, and now we are in the process of it. So my point, implementation is a key aspect. You should look into that, and also in implementation science, I recommend you that you look into that. It follows an obvious or a very logical process, which is you identify some objectives, you identify which are the barriers that are against achieving that objective. You plan some strategies to overcome these barriers, and then, you execute and assess the process. And that's a continuous improvement process that is helping us to better scale these projects. The good news is that we are developing in there something called It Fits Toolkit that will be available for all of you anytime soon when we have tested it in the project, and will help people go through all these steps. So my final thing, and that's good and bad news. There's a lot of evidence and use cases about scaling up, but there's no magic formula that will guarantee you that you are able to scale up any innovation. You think that you will be able to manage timings, but all the time it will be slower than you think. Money can help kickstarting the process, but not always helps, and I have plenty of experience into that. Evidence may help, but it must be used in the proper way. You must make the evidence be understandable by people. And the last one is that, you can plan as much as you wish. We have heard before that, that planning was really, really important, but, plans will change every other minute because, reality is complex. And that was the thing. Thank you.
Thank you. So we have some virtual questions, and of course you're welcome to, I'll take the virtual one first, and then I'll give the microphone to you. So the most popular question is, what are the key things you would teach to future medical professionals?
That's a tricky one. No, I think that, it's what I was telling you before. They must learn that now the information is available for everyone, so there is this democratization of the information, and there is it's the slide that I try to put in there. Patients and citizenship want to be part of their cure process or taking care of their own chronic conditions and all the stuff around it. Some physicians are keen on accepting that and making people inside of the loop, while others are not. I think that there should be some specific training into that. Thinking that they are not the only holders of this knowledge, and also, some specific training on digital solutions probably that they don't have. I think people that is coming today from the faculty, they don't have this training.
Thank you. Can we give the microphone to the gentleman over here?
Hi, thank you for the presentation, and it was really interesting. And actually, my question would be that you mentioned a lot of obstacles on the way, and people don't want to change, etc. Can you elaborate a little bit on the business cultural change? Who is driving it really, and what is kind of practical procedure? How do you do it to basically focus on innovation more or less every day in the organization? Thank you.
Yeah, thank you. Very good question. We have tried to put in place a culture of innovation at the organizational level, where we try everyone to be involved within the process, and the person that has introduced, not necessarily a clinician, the person that has introduced the innovation, to be the leaders of the project. Our approach is, I would say, in two sides. The first one is involving everyone since the very beginning, so they feel really part of it. And it's, really taking advantage of a bottom-up approach, themselves being the leaders, and themselves being able to construct the team that is moving forward with the innovation. That's one part. The second part is involving not only the people inside of the organization, but also adding, as Terje was saying before, the patient perspective. This is something that we do through the health boards. These health boards where we have people from academia, from civil society, from service provision, and from industry, we bring them into the loop because the innovation may require some technological development. If we are not able to do it, we will present that to the industry in order for them to help us and then reach a deal in between the industry and ourselves and the innovator for this innovation to be developed by them. Then they get a bit of the exploitation rights, and then we get the intellectual property, and we have some rules, the ones that Terje was saying that they were writing, we have them already established. And I think that the most important part is, one of the most important parts is the patient perspective. So from these health boards where we have parents associations from schools, where we have patient organizations, where we have expert citizens, we involve them also in these discussions. We have this project, and we would need patients to be part of the design process. So the idea is to involve people since the very beginning, including patients in the design process, and move all the way until the end of the project with them in assessing and reassessing and assessing and assessing and reassessing. So that more or less has worked pretty well for us.
Thank you. Go ahead.
I have actually more a comment than a question. And if you don't mind, I will do it in Estonian actually. Ma tahaks teie tähelepanu juhtida ühele lühendile, mis siin ühel slaidil oli, EIP AHA, mis on European Innovation Partnership on Active and Healthy Aging. Selle raames, kui mina nüüd aprillis lõpetasin Euroopa Komisjonis, see oli meie Unitis see projekt ja seal ei olnud Eestist mitte kedagi. Aga seal on terve hulk igasuguseid neid twinning projekte, milles saab minna ja õppida kellelgi, kes on midagi innovatiivset oma tervisesüsteemis, haiglas, piirkonnas rakendanud. Et vaadake selle kodulehele, minge vaadake sealt midagi, mis kusagil toimub, seal on kõik üleval, neil on oma marketplace ja kõik asjad, kus projekte tehakse, mida tehakse, ja siis saab selleks ka taotleda Euroopa raha, et minna ja õppida teistelt piirkondadest, kus asi toimib. Pidage silmas Hispaania kolleegi, hispaanlased on väga kõvad tegijad seal valdkonnas. I just told them to keep eye on you and write down your email address because the Spaniards are so good on using the EIP on active and healthy aging for twinning purposes. Be careful.
Yeah, so you'll be getting a lot of emails. Any other questions? Yes, where is the mic? Over here, please.
Hello, thanks. How long is a typical project or a pilot? In your kind of experience, I understand the success rate is 2 scaling out of a total of 10, something like this.
Well, that was the example of European projects, and it's what I told you. Don't take it as a rule, because there were some projects that did not scale, not because of the project was not good to scale, but because of the framework conditions, such as the financing system, what I mentioned before. I would say, it's what I was saying, I don't think there's a magic recipe, and if you are asking me from the pilot to scaling, it will depend on the length of the pilot and the complexity of what we are going to assess. For example, if we are working on behavior change, we know that any project around behavior change, with 6 weeks, we are normally able to see changes in behavior of people. Then if we want to see that whether those are sustained or not over the time, we may wait, I don't know, an additional 6 weeks more to see whether to have a final assessment and to see whether those are maintained or not, or sustained, and then we produce the scientific evidence and when we try to scale up. So all in all, for a short project such as behavioral change, this may take, I don't know, 5 months from pilot to scaling up. But then there are other projects when you are trying to see, I don't know, maintaining the chronic conditions of a certain patient because of telemonitoring and telecare solution. Those ones may have a longer observational period to do the pilot, and then everything is delayed. I don't have a specific number.
Any other questions anyone wants to ask or comments? I'll take another one from here. Another popular question is, how has Catalonia tackled with interrupting the medicine faculties? Do you understand the question? Because it's if the person who wrote it, you can elaborate on that, because I'm not sure I understand, but this is how it goes. How has Catalonia tackled with interrupting the medicine faculties? Can anyone who wrote this question elaborate, either in English or Estonian? Yeah.
Basically, how have you changed? Because one of the things you mentioned is that we have to change how academia is working right now. So how has your region worked upon it?
We have not managed to do that. I mean, wherever I heard that someone of you in Estonian, there were some slides and some of you said, medicine was conservative. My point is that, I also think so. I mean, I strongly believe that they are very conservative, and we have raised that issue. I mean, they know, but of course, we are nothing next to a medicine faculty, so we have not managed. What we have seen, or with the people that we have worked super well and we have very good experiences and we have a strong collaboration, is with the faculties of nursing. But with the faculties of medicine, they remain hermetic and teaching the same way they did the past, I don't know, 200 years. That's my feeling. So we have not managed that. They know that, and there's discussions, and I know physicians that are raising this discussion to the boards of the faculties, but everything moves really, really slow in there.
Does anyone have any ideas how to speed up this process? How to reach out to universities and other faculties? Sorry? They have to recruit younger people. That was a suggestion from here. Any other ideas? That's like an open discussion. It seems to be one of, You
just employ more people who say, no, I've had enough of this rubbish that's been going on for 20, 30, 40 years. No, not all rubbish, most rubbish for 20, 30 years. And we've seen that in the NHS in England. People who've turned around and said, no more empires for people who've got too big empires themselves as consultants. No more are we going to put up with poor service. No more are we going to put up with no involvement with patients. And it's about time. So people need to say no more.
Yeah, so the power can always come from the people. So that's where the change can come from as well. Anyone else got motivated to share their ideas? No? Well, thank you very much. Let's give a round of applause. We also have a gift for you.